Good morning and welcome to the opening plenary of the Isdell Flowers Cross-Border Malaria Initiative Virtual Roundtable. This session is in webinar format, which means that you will not be seen or heard. As the day progresses, we will be guiding you through the links that you will need. However, if you would like to join in at a specific time, you can always find the relevant links on the website at jcflowersfoundation.org/roundtable. If you're ever lost, that's the place to go. You will also see the full agenda there. If you have any technology questions, please email mmugore@jcflowersfoundation.org. We will put that address in the chat bar. Now I will take you through the controls that are available to you. If you move your mouse or tap on the phone screen, you should see various icons appear. The chat icon allows you to send messages to other participants or to the meeting host. Go ahead now and write your name in the chat and tell us where you're coming from. It's a way to test to make sure that it works. The question and answer is where you will go to type in questions. These will be addressed at the end of each session as time allows. Finally, you can choose the globe for Portuguese translation. Todas as sessões plenárias serão traduzidas para a língua portuguesa. Para ouvir tudo em português, basta clicar no globo embaixo e escolher português. Já vai ouvir diretamente em português, mesmo se o palestrante estiver a falar inglês. If some of these controls do not appear when you move your mouse or tap your phone screen, you should click the 3 dots to the right of the toolbar labeled More, and they should become visible. Now I would like to introduce you to the founder of the JC Flowers Foundation and president of JC Flowers & Co., Mr. Chris Flowers. We are grateful for Chris's long commitment to malaria control and elimination in the remote border areas of Angola, Namibia, Zambia, and Zimbabwe. I turn it over to you, Chris.
Thank you very much, Rebecca, and good morning, good afternoon, and good evening to all of you. We welcome you to the annual Isdell Flowers Malaria Initiative Roundtable, the first ever held online. And though we missed some parts of meeting in person, staying up late to debate with old and new friends, grabbing a cup of tea together, and possibly even dancing together along with the beats of the Malaria Choir, we are also grateful that this format allows the participation of many more people. We are delighted to gather today over 300 participants from 35 countries around the world. We know many of you, but others of you are new to us, and we hope to get to know you better one-on-one in the future. And for those who don't know us, the Isdell Flowers Cross-Border Malaria Initiative is committed to malaria elimination through community mobilization along the shared borders of Angola, Namibia, Zambia, and Zimbabwe. We believe that malaria can be eliminated only if those most affected have the knowledge, skill, and resources to prevent and treat the disease and to advocate for its elimination. Because the vast majority of people in these regions describe themselves as people of faith, we have worked closely with local churches in implementation, first with the Anglican Church and now with the Methodist Church as well. Over the decade, Isdell Flowers Cross-Border Malaria Initiative partners have worked with networks of local faith organizations and community volunteers in collaboration with ministries of health, using strategies that are, firstly, community-based, because people living in endemic communities are experts in local realities and ultimately determine the success of malaria elimination efforts. Secondly, cross-border, because parasites and mosquitoes do not respect national boundaries, and many families live on both sides and cross frequently. Thirdly, in partnership, because all are stronger when bringing out the best in each other and walking together as a community of scientists, local leaders, national governments, religious bodies, and multilateral and nonprofit organizations. And fourthly, focused in last mile communities, which are often remote and economically poor, but where malaria elimination is essential. This is a critical time for our collective malaria elimination work. We recognize that globally, the dramatic progress against malaria made during the last 2 decades has plateaued in some areas. COVID-19 has challenged us further, though we are grateful that COVID did not provoke all the malaria setbacks that we feared it might. In our own work, we have been delighted to see that the community networks have been able to maintain essential malaria diagnostic, treatment, and education work despite COVID-19, partially due to the trust that community members have in their fellow community health workers, and due to their own intrinsic motivation, as the health of their own families is at stake. Community malaria leaders have also strengthened the COVID-19 response by serving as resources of reliable knowledge and by encouraging COVID testing where appropriate. We believe that bringing community voices into various discussions about malaria elimination is critical, and have done our best to bring those voices into this meeting. Because internet quality fluctuates dramatically, we have pre-recorded some statements from the more remote communities, but the speakers will be joining us live during these sessions to answer questions should their internet allow. For those interested, there will be time set aside at the end of the sessions today for a more in-depth conversation. We hope that you hear the perspective of someone whose voice you don't regularly have a chance to hear, and that this catalyzes creative action for malaria elimination within your own context. With that, I'd like to introduce the Honorable Joy Fumafi, currently the Executive Secretary of the African Leaders Malaria Alliance, who will be moderating our opening plenary. She has previously served as the Assistant Director General for Family and Community Health for the World Health Organization and as Vice President for Human Development at the World Bank. As a Botswana national, she has also served her own country as Principal Local Government Auditor, as a Member of Parliament, and as Minister of Health. I pass it to you, Madam Fumafi.
Thank you so much, Chris. It is an absolute honor to moderate this distinguished panel. And of course, an honor as well to recognize and appreciate the amount of work that your foundation has done in cross-border collaboration in the fight against malaria. We are all aware that we still have a long way to go, and that though we have made considerable progress around the world in the fight against malaria, we are beginning to see regression in a lot of areas. And some of the areas extremely worrying, like for example, malaria in pregnancy, where we have 33 countries in which 822,000 children will be born with low birth weight. And this is just an example. It's not mortality, it is extreme morbidity, which is going to affect learning outcomes and potential of these children. But the mortality continues to be totally unacceptable. And the pandemic that we're experiencing now, the COVID-19 pandemic, demonstrates very effectively how critical it is for us to have cross-border collaboration, how important it is for us all to work together. And I'm hoping that this panel today will be able to demonstrate effectively, not just how cross-border collaboration is important, but also how important it is for different communities to work together. We have a distinguished panel with us today. We have Peter Sens, the Executive Director of the Global Fund to Fight AIDS, TB, and Malaria, and who will be tying in both malaria and COVID-19. We have Dr. Raj Punjabi, the US Global Malaria Coordinator for the US President's Malaria Initiative. And he is a very distinguished global health expert who founded the organization Last Mile and has extensive on-the-ground experience working on the African continent in developing countries and reshaping inequities in health systems. We have Dr. Joseph Mberikunashe, Director of Zimbabwe's National Malaria Control Program. And he will highlight Zimbabwe's success in achieving the high IRS coverage and acceptance. Zimbabwe is an extremely unique example of a health system that is working effectively simply because it has committed health workers and not because of the resources that they have, because they have limited resources. But it just goes to show how important commitment, leadership, and engagement of communities is. We have Reverend Yobo Jere. He's a priest and malaria advocate from Livingstone, Zambia, who is going to show us exactly how the community can work together in order to promote the health of his parish and his members. Justina, I beg your pardon, Sangoma Ndibi is going to be sharing with us the experience now of the traditional healers, and we are very, very fortunate to be able to experience this member or leadership in our communities that is very, very popular, particularly in some communities. This is the first place of call when a child presents with malaria or an adult presents with malaria. We have the program manager from the Namibian Anglican Community Development Organization, Dr. Ndakundana Hamukwaya, and she is going to be talking about community-based testing, tracking, and treatment. And we have with us the Director for Malaria at the Bill and Melinda Gates Foundation, Philip Welkoff, who is going to round us off, but also talk about some of the very, very groundbreaking work that has been done currently by the Bill and Melinda Gates Foundation, but also linking it with the current pandemic. It is now my distinct pleasure to call Peter Sens, Executive Director of the Global Fund to Fight AIDS, TB, and Malaria. And he is going to talk to us about malaria and COVID-19. Over to you, Peter.
Thank you, Joy. And thank you, Chris, as well, and to the Isdell Flowers Cross-Border Initiative on Malaria Elimination for giving me the opportunity to join all of you. I am conscious that I've been asked to talk about the importance of local and community-based interventions, but there are many people who are going to be speaking on this panel who have much more direct experience, and I am looking forward to listening to my other panelists to learn from you about your experiences in actually delivering community-led interventions for malaria on the ground. That said, I don't need any convincing, and the Global Fund does not need any convincing of the importance of community leadership in the fight against malaria. And indeed, I think it's one thing that the malaria community can teach or bring to the COVID pandemic response. In many countries, the COVID pandemic response has been very top-down, very medical, sometimes almost kind of militaristic in the way that it has been implemented with the imposition of lockdowns and so on. And I worry that we have been slow to learn the lessons we have learned in the fight against malaria, against HIV and TB, which is that real victory against the kind of formidable pathogens that HIV, TB, and malaria are, and COVID is as well, requires leadership at multiple levels and leadership within the communities. And in fact, I think even now we can see a year into the COVID pandemic that one of the biggest determinants of whether or not a country or a community has combated COVID effectively is
Of course, the importance of availability of biopharmaceutical tools, of vaccines and drugs and diagnostics and things, but actually probably the single biggest determinant has been whether there has been leadership in those communities and whether the people believe what they're being told and are willing to change their behaviors in ways that help combat transmission because they have faith and trust in their leaders. That's a lesson that, in a sense, we've learned a long time ago in malaria, but we seem to be having to relearn all over again in the fight against COVID. Stepping back a bit from the question of community leadership and its importance both in the fight against malaria, but also in the response to COVID, I think it's worth reflecting on where we are. I think we are right now in an extremely challenging period. In many of the countries most affected by malaria, COVID is actually on the increase, and its impact is underestimated because testing levels are too low to give an accurate picture of what is actually happening. And we need to worry about that both because of its direct impact, but also in many of the most heavily burdened with malaria countries because of its indirect impact on the delivery of malaria services. In 2020, we were all very concerned about what would happen to things like bednet campaigns in an environment of lockdowns, of worries about of COVID, of social distancing. But actually, I think the malaria community, both globally, regionally, and at local level, did a tremendous job at ensuring that sometimes they were a bit late. They often had to change the way they worked, but actually most bednet campaigns and IRS type campaigns actually still happened. And certainly the Global Fund was monitoring national bednet campaigns across 38 countries. And as I say, some of them were a bit late and a bit delayed, and we certainly had to put resources into changing the way they worked. But working in partnership with PMI, with governments, national malaria programs, and communities, actually, it was a better outcome than I would have hoped for sitting here 12 months ago when we first saw the crisis unfolding. But I think we need to be anything but complacent. I am very concerned now as to what happens with malaria case management. We're seeing increasing pressure in many countries on community health workers, who are the absolute backbone, the lifeline of case management, of early diagnosis and treatment of malaria cases. And we know that if community health workers start getting infected, or worse, they die, there's very little backup in many communities. And we also know that if case management, of diagnosis and treatment is delayed, you very quickly with malaria see an uptick in mortality. So I think one thing that both the global agencies like the Global Fund and PMI need to do, and working with communities, is ensure we protect and sustain the people who are actually delivering care on the front line, because without them, we don't really have a system. And without them, we could see a very sharp deterioration in mortality. My last observation, just quickly, is that I think we should both see COVID as a huge challenge and be very clear-sighted about the scale of the challenge that we face. But we should also see it as a catalyst to think differently. With COVID, we have seen that the world can advance science at an incredible pace, that it can do things very differently, and that it can put enormous amounts of resource to save people from an infectious disease. It's actually quite shocking in comparison how little we spend globally on malaria relative to COVID. Malaria is a disease we know how to fight, we know how to cure, we know how to deal with. We're only spending relatively small amounts of money on it, less than 1% of what we're spending on COVID. And I think we should use this as an opportunity both to challenge ourselves in the ways we work and fight malaria, but also to challenge our aspiration and say, in the same way that the global aspiration is to get rid of COVID-19 everywhere, well, while we're about it, why are we still fighting malaria? Why aren't we getting rid of malaria everywhere? I'll stop there, Joy, and look forward to the comments from the rest of the panel.
Thank you so much, Peterson. Very important question. Is it not time now to build a new normal where we get rid of some of these old challenges that continue to debilitate our communities? Very important question. Our next speaker is Raj Punjabi, US Global Malaria Coordinator for the US President's Malaria Initiative. And he's going to talk us about the importance of recognizing and valuing community health workers, which is exactly what Peter was talking about. What are we doing to protect our health workers? Over to you, Raj.
Thank you. Thank you so much, Joy, and thank you to Rebecca and Chris for the invitation today. I want to just build on Peter's excellent comments, and I want to start by giving you all a break. I know if you're like me, you've probably been staring at your screen day in and day out and started this morning. So I'm going to give you a break from your screens. I'm going to ask you to close your eyes and imagine. Close your eyes and imagine. Don't close your eyes and fall asleep. Imagine you're living in a village in West Africa. Imagine, like me, you're the parent of a 3-year-old, and she wakes up one morning with a fever. And you know she could have malaria, and you panic because you realize the only way to get the medicines your child needs would be to carry her on your back, paddle a canoe across a river, and then hike over log bridges and across the mud in the forest for up to 2 days to reach the nearest clinic. Now open your eyes. Half the world lacks access to essential health services. We know that. We estimate about 1 billion of these people live in the world's most remote communities, where while we've made great advances in modern medicine and technology, our innovations have simply not reached those at the last mile. There's still too many children in these communities that still go without a single dose of medicine to treat malaria. We know from the World Malaria Report recently that 31% of children with fevers don't have those fevers tested for malaria. Many of them come from these communities. There are still too many families that go without a single bed net to prevent a mosquito bite. We've seen these communities left behind because they've been thought too hard to reach and too difficult to serve. So if there is one important overlooked strategy in malaria control, and in global health for that matter, it's putting the last mile first. It's going as far as it takes to reach the unreached, even when that's the hard thing to do. We know from the science to end malaria, we have to reach the unreached. That's why I'm particularly proud to be here, because the cross-border malaria initiative that Isdell Flowers has been working with partners in Southern Africa on is focused on remote, hard to reach border communities. Together, I know we've worked to support the latest Universal BedNet campaign in rural Angola, to spray insecticides inside homes in rural Zambia, to develop creative resources to educate and empower, like the Chikunda language audiobook for mothers in rural Zimbabwe. And these are really critical initiatives that have helped us make progress in the fight against malaria. Generally, as my good friend Peter said, at the Global Fund, I know Philip feels that way at the Gates Foundation, we have to prioritize continuing to reach the unreached. Alma has called for the same. Quite simply, if we want to end malaria, we have to decrease deaths and disease at a faster rate than we have done recently. And we have to do that by making sure proven interventions, tests, medicines, nets, sprays are within reach of the world's most remote communities, those areas with the highest malaria transmission and where the lowest intervention coverage is. The second overlooked strategy, and it's related to the first, to reach these communities, we have to do more to invest in people closest to those we wish to serve. Health systems are often out of reach. And what we have found in our work, as I know is the case for many of our partners on the line, is that it's communities and faith leaders that can create a bridge when the formal health system is unreachable. USAID's in fact worked for decades with faith-based communities. We have a policy framework that focuses on that. And what we found at the work at the President's Malaria Initiative is that when those faith and community leaders collaborate and work with community health workers, we can actually see a dramatic improvement in malaria control. Let me tell you about one, Agatha, a community health worker I was making house calls with a year ago in Liberia. Agatha has been living in a community called Bo. It's about 2,000 people spread across 9 villages in the rainforest. To get from one village to another, you've got to walk through footpaths. You have to be ready to get mud on not only your shoes, but your shirt. Agatha serves the daily health needs of her neighbors in this community. And when there's a condition she can't care for, of course, she works with outreach nurses and gets those patients to clinics and hospitals. Prior to becoming a community health worker, Agatha had reached the 9th grade, but her parents couldn't actually afford to send her to high school. So she went the large majority of her adult life to that point without a job. But months before I met her, thanks to the work of many here, the Gates Foundation, the Global Fund, President's Malaria Initiative, the Ministry of Health, but especially the local community and faith leaders, she was able to be hired as a community health worker. She got training from a nurse, she got medicines, tests, and supplies. She was given a smartphone with video lessons on how to assess a child for malaria and malnutrition. Now, I've visited Bo many times since I was a medical student. I used to hear stories of children dying from malaria and have access to medicine. But on my last visit, Agatha took me to see a patient of hers, a 5-year-old girl, who had fallen violently ill with vomiting and fever, and her mother had rushed her to Agatha's doorstep. Instead of that child dying or falling sicker, I was watching that child get ready to walk to kindergarten. It was because Agatha had been able to provide the medicines that that child needed and certainly healed her and possibly saved her life. This is not the story of one community, as we all know. Today in Liberia and in many of the countries we work in, Rwanda, Zambia, Ethiopia, for example, Senegal, growing numbers of children and families are treated and tested not by doctors alone, but by their neighbors, community health workers like Agatha. They are now, as Peter said, risking their lives to find patients with COVID-19 and get them into care, to carry out contact tracing in some cases, to get communities ready for the vaccine, for the COVID vaccine, and ensure that people have access to masks. But let's just remember, the world is facing a huge shortfall of health workers. Before COVID-19, we were told that there could be as many as we'd face an 18 million health worker shortfall by 2030. We need more doctors, we need more nurses. We also need more community health workers like Agatha. And in fact, the science shows if we hired and trained and equipped workers like Agatha, we would be everywhere they're needed. We would be able to save an additional 3 million lives every year. So COVID is a huge threat to these workers, as Peter already brought up. And let me just say, as someone who's worked in COVID clinics, who's volunteering this weekend in a vaccine clinic, I can tell you the anxiety you feel when you are worried you don't have protective equipment is unlike any other kind of anxiety. And yet, community health workers still, in some parts, go without masks, knocking on doors in the poorest neighborhoods to find COVID patients. Without face shields, they try to deliver bed nets. Without gloves, they canoe across rivers to deliver vaccines to families in the rainforest. Thousands of unprotected health workers, community and otherwise, have died. In fact, a recent Amnesty International report showed that over 17,000 of them have died because of COVID. So while we might applaud health workers, we might applaud community health workers, applause is not enough. If we respect them, we have to protect them. That is one key part of investing, not just in the services they provide, but the systems, including the supplies that they need. And then we have to go farther than that. We have to invest in their careers, in their dignity. You know, if we dream of a future when millions of people like Agatha gain dignified jobs as community health workers to serve their neighbors, if we want to see that happen from the forest communities of West Africa to the fishing villages of the Mekong, from the hilltops of parts of Southern Africa to the mountains of Central Asia, well, to realize this dream, we've got to confront a challenge. And here's the challenge where we need your help. Most community health workers are poor. Most community health workers are women, and most community health workers are still not paid. In fact, I was surprised and shocked, frankly, a couple of years ago when the World Health Organization unveiled new data that showed that the poorest women on earth subsidize healthcare globally to the tune of over $1 trillion every year with their unpaid labor. $1 trillion. That's a figure larger than the economies of over 150 countries. Now, look, I think there's a place for volunteering in society. I mentioned I'm volunteering at a clinic this Sunday, but people should choose to volunteer, not have to be forced to do it. If, as a doctor, I'm not expected to go without fair pay for my work, then why would community health workers, women or men, not be paid fairly for theirs? Again, the good news here is that this isn't just the moral thing to do, the right thing to do, the equitable thing to do, it's also the smart thing to do. The science shows for every dollar we invest in training, equipping, and hiring a community health worker, that returns $10 to the economy through saving lives, stopping outbreaks, and creating jobs. It's also in numerous countries in controlled studies shown that you can improve malaria care, primary health care. It helps community health workers like Agatha earn an income so she can finish high school and eventually go to nursing school to pay for her children's school. You are leaders in engaging communities. So I'm going to ask you for help, not only in this. We need your help to change this condition. Over 190 governments have already made commitments to invest in creating jobs for workers like Agatha. They did that in the World Health Organization's Community Health Worker Guidelines in 2018, where financial remuneration as well as contracts for these workers is strongly recommended. They did that in 2019 when the UN Declaration for High Level for Universal Health Coverage committed to invest in jobs. They committed to invest in them, to pay them, to protect them. But we know that power is never given. It must be demanded. So what we need your help to do is to join with community health workers like Agatha, call on local governments, call on global and regional organizations like PMI, the Gates Foundation, the Global Fund, ALMA, ask us to do more. Ask the healthcare organizations in your areas to go as far as it takes to invest in these workers, to invest in the people closest to those we serve. We all know illness is universal and healthcare is not, but no community health worker has to be overlooked. No community has to be left behind if we're willing to go as far as it takes. Thanks, Joy.
Thank you so much, Raj. Powerful words indeed. In fact, I come from a continent where 93% of the population is religious. So religious leaders are extremely important. And every 2 minutes, we lose a child to malaria. And we could easily avoid these deaths if we had community leaders, community health workers who were available in the community as when they were needed, well equipped, and as you say, protected and reimbursed so that at least they don't continue to live below the poverty line, which is what is happening with most of them. Our next speaker is who is going to speak is Dr. Joseph Mberekunashe, and Dr. Mberekunashe is the director of Zimbabwe's National Malaria Control Program. Doctor.
Thank you very much. Thank you very much, Madam Chair, and greetings to all colleagues, ladies and gentlemen. I am having a little bit of a challenge with my connectivity, so I'll ask Rebecca to play a pre-recorded speech, and then I'll be available also for questions. Over. Rebecca. I would want to talk about a special strategy that has been known since time immemorial in terms of prevention of malaria and achieving elimination, focusing on our experience in Zimbabwe. And that strategy is indoor residual spraying, or IRS. IRS refers to the application of insecticide or chemical on the wall or the inside wall of dwellings or houses, as we all know. The aim there is that the mosquito, as it comes into the house, it will land on the wall and absorb the chemical that will kill it. We have used IRS since 1949 in the country. The reason why we use it is we believe it is the best strategy, and it has also been used elsewhere to achieve elimination. And I'm sure all of us are aware of that. We use IRS in originally 59 districts of our country, and we've now sort of slowed down to 31, and we have seen the results bearing fruit. Our pillars for the successful implementation of IRS are around a good country ownership in terms of development of policy guidance and clear strategic plans that defines who does what, where, and when, and how. We also have a very strong community ownership. The community structures take a part and parcel of the implementation in as far as planning is concerned, mapping of where we do the operations, resourcing, staffing, recruitment of who does the work, and the actual implementation, including supervision. The community structures, the leadership, church leaders, traditional leaders are the soul of the program that we have seen evolving over time. We also use evidence for what we do, be it epidemiological data in terms of mapping where the burden is highest and where it's not as high, and also the behavior of the mosquito, what we call entomology. We also use that to plan our operations. And just focusing on the epidemiology and the communities themselves, as well as the mosquitoes. A little bit of that is evidence has shown us that in Zimbabwe, most of our people in the areas where we spray tend to like to sleep indoors at night up to early mornings. They are just afraid of sleeping outside, I suppose, whether it's animals or what, but that's a reality and that's an advantage for us. The mosquitoes also that we have, Anopheles arabiensis and venestas, they also tend to love to go indoors, to rest indoors, and to feed indoors. So when we apply the chemical indoors, we are almost done. So we have the communities then that map where we spray. In terms of mapping where we spray, our areas where we spray tend to be the areas where there's stable community structures. And they tend to build more permanent homes, hence they are sprayable. And that's very important in terms of risk stratification of areas where you spray. What is the advantage of using IRS? Like I've said already, IRS is put inside the house, and our people tend to love to spend most of their time indoors. So all they have to do is to be indoors during the peak periods of biting for the mosquitoes. And it does not matter which room we're talking about, be it the kitchen, the dining, the lounge, and the bedroom and the other dwellings. We spray all of them, and that increases the surface area for contact with the mosquito. And so all the person has to do is to be indoors. It's a suitable strategy also for the disabled, the elderly, who do not have to remember a lot more things that need to be done before we are protected. So we see those advantages. The fact that the community participates also makes it very sustainable and cheaper because they provide the labor force, they provide the logistics that is required. The coverage tends to be high and of good quality because they are the owners of the homes, they are acceptable by the communities that also select them for the operation. So what is the evidence that we have seen for our success in the country. Like I said, we started by spraying 59 districts in the country over time, and 32 of those districts out of our 62 in the country, which gives us about 51% of the districts, have started to do elimination work. They moved from control to elimination due to IRS. We're only giving IRS in those areas. And 7 of those 32 districts have been recording consistently 0 malaria cases locally. And that is a good sign. Originally, these districts were reporting malaria incidence as high as over 300 per 1,000 cases. Now this is 0, like I've said. And if this is not success, I don't know what is. But we have areas where we also use nets, and it's guided by WHO. We don't combine, but we do stratify our areas. And where we definitely see there are no sprayable structures, the nets are the choice. So we are not at all against it. The other example, exactly where nets work, is we know that there are people that are displaced, internally displaced, which sometimes is even temporary. They cannot build more structured homes. Refugees, for example, people who are running away from war, instability and all those are, for us, they fit a criteria for needs. And I believe that if we all in the region started to re-look at our strategies and deploy them like we do, we are open to having exchange programs with colleagues so that we can also see how we do it. We believe that we can all achieve elimination. So IRS is still working. IRS is still the best tool. It gives you an opportunity to continuously interact with the communities periodically and change gears if there is need. Particularly if you face challenges of resistance, you can also rotate the chemical, you can use mosaic, and that works. So I urge all of you to buy into IRS once more so that we achieve elimination. I thank you.
Thank you so much. Zimbabwe is, they are the stars in our region in terms of just work ethics and ability to work as a community. And this is another example of how successful the country is in pulling together in combating adversity. We have with us Reverend Yobo Jera. He's a priest and malaria advocate from Livingstone, Zambia, and he's going to speak on the promotion of community ownership of the malaria response. Reverend, you have the floor, sir.
Good afternoon, distinguished guests. My name's Father Yobo Jere, working under the Anglican Diocese of Lusaka, and I am based in Livingstone. I should mention to say that I was touched to have been asked to participate in this distinguished panel of experts at this roundtable conference. I should also mention that combating malaria is without doubt an issue of global urgency. And I am encouraged and inspired to see how real the determination of the international community to overcome this dreadful disease. And in this respect, I would like to recognize Isdell Flowers Foundation and the Ministry of Health in Zambia for their tireless efforts to eliminate malaria. However, it is tragically evident that much still remains to be done. Ladies and gentlemen, I have been lucky enough as a priest to visit homes of people in Livingstone and beyond for the past 5 years. During my pastoral visitation, I have often witnessed at first hand the devastation that malaria can wreak on communities. I have seen people dying due to malaria, and some I have even officiated at their funeral services. I know of a woman who is a member of my church, Pamela. Her story is very interesting. She became pregnant in 2015. Pamela was overjoyed at the prospect of becoming a first-time mother. But then she contracted malaria, and it developed into a high fever, and sadly, we lost her baby due to a mosquito bite. Pamela channeled all her heartbreak into ensuring that no other mother would experience her devastating loss. She became an activist, a local woman training pregnant women and young mothers on how to protect themselves and their children against malaria. In 2018, Pamela became a mother, sleeping under a mosquito net and taking her anti-malaria treatment. She gave birth to a beautiful baby girl. Pamela has continued to help save lives through her work as an activist. Therefore, this simply means that malaria prevention must go hand in hand with community participation. Unless individuals in the community see the importance of preventing the illness, the best designed strategy may not work out. We have learned that top-down government and stakeholders' investment is not enough. Experience shows that no matter how near we are in achieving zero malaria cases, we are stronger working together from communities upwards. We are stronger pulling our resources and efforts together. We are also stronger when government and the stakeholders, through community-led action, engages in the fight against malaria together. We need, therefore, to have many community programs which can relay the message and bring out sensitization to the community, such as the use of soccer events, such as weddings and community fairs. Children at school are also important change agents. The youth groups can be mobilized to assist with messages to reach home. By educating the children on the benefits of preventing malaria, we can be assured that the children will also share the same message to their parents at home. In addition, winning over community members require leading by example, as it can be seen on my other photo. Yes, as we can see on this photo, we had gone to one of the villages in the community, and we were trying to explain to people, to explain to the community on how best we can prevent ourselves from catching malaria. Well, as we also can see here, we were with my Bishop of Lusaka. We were sensitizing the community health workers, the community, also on the dangers of malaria. Here, I was actually leading by example. I did a malaria test, and I thank God it became negative. Okay. So when people see me getting tested as a priest, they also come because I'm leading by example. And it's important on the part of community leaders. They need to be the first to open up their houses for residue indoor spraying. When community members see that the houses of their leaders have been sprayed, they easily follow. When community people see that their leaders are being tested, they also follow suit. When community members see their leaders are taking malaria tablets, they also follow suit. Another incident is when we went with the team to Libuyu to get people to test for malaria. After mobilizing the community together, me as a priest and dressed in my robes, I was the first one to be tested. This I did to show the community members that I believe in what I preach. After everyone tested, I prayed and offered a blessing at the end. Okay. This way, I am saying to the community that conventional medicine and prayer are going together to heal someone who is not feeling well, to heal someone who is sick of malaria. So once I pray for someone who has already taken Fansida, people believe it and they have faith and hope that they will recover. The church, my brothers and sisters, is a social partner in combating malaria. And many people attend the church and they have a lot of trust and confidence in the church leaders. I should mention that church leaders are not doctors, but they are leaders in the community who are highly respected and trusted. Finally, regardless of the specific approach, I should mention that collaborating with the community is very important and cardinal in combating malaria. In doing this, when the community themselves own the prevention, it becomes sustainable and it is good for the health programs. I thank you.
Thank you so much, Reverend. Very, very powerful words indeed. Stronger together, build ownership by the community, work with children and young people as change agents, lead by example. Thank you so much, Reverend, for leading by example. We are now continuing with our community engagement session of the panel, and we are going to be fortunate to witness Sangoma Ndibi, a community health worker in the Sesheke district in Zambia, who is going to demonstrate the critical role that traditional leaders can play as change agents themselves in their community.
I'm Sangoma Ndibi, a malaria volunteer here in Mount area. I joined Isdell and Flowers Foundation in 2010. I think there are some people are confused, yes, looking at my age, why I'm doing a voluntary work. But you see, we want to do away with the diseases so that we can have development in our country. Where we can combine with other people I think we can achieve what we want to do. Isdell and Flowers Foundation came in, and we are able to. We were trained to fight against malaria, and our fight against malaria may lead to the elimination of that disease, and then development will come because our people will be free from diseases. The community members are calling me a doctor because I'm able to detect malaria in their bodies and even give them advice on how to prevent themselves. So usually I'm called a doctor. We are very proud of the outcome in our areas. We are very proud.
Joy, you're muted.
I beg your pardon, community engagement is absolutely critical to the elimination of malaria. And eliminating malaria means development for the African continent. In fact, we are losing an estimated $3 billion a year by not eliminating malaria. Very powerful message. We now have Ndakundana Hamukwaya. She's a program manager from the Namibian Anglican Community Development Organization, and she's going to talk about the community-based testing, tracking, and treatment. Ndakundana, you have the floor, please.
Yes, great. Thank you, Joy, for the introduction. As she has mentioned, I'm Ndakundana Hamkwaya, and I'm just going to share with you about the community testing and treating. So because my network is not really okay, so I'm gonna let Rebecca play the video that we recorded, and I will be here for questions. Thank you. Okay, good afternoon. I'm Ndakundana Mkwaya from Namibian Anglican Community Development Organization, known as NACDO. I'm here to discuss with you briefly on the community-based active case detection and treatment for malaria. As a country, Namibia is in the pre-elimination stage of malaria. So it's very important for us to get rid of all the last or each and every last case. So we make sure that we do not have people who are spreading malaria in our communities, so we are able to get rid of malaria. If you can look at the data there, you can see that we have very low numbers of cases in the country. That's why we are at the elimination stage. And it's very vital for us to make sure that we do not have people who are spreading malaria. So each and every person who has a malaria case is treated, and there won't be further spread of malaria in the communities. Next. On the active case detection. So what happened is that we have small urgent active case detection teams who go out in the community. Once the case is detected, they go and follow that case within 72 hours to that specific household where the positive case is detected from, and all the members within that household are detected. This is actually very important because we want to make sure that all positive cases are detected and they are treated, so there won't be further spread of malaria. And in these cases, we also identify areas, or let's say communities, that have reported most of the local cases, where now a mass testing team is sent there to do the testing to all the members within that community. This is done in collaboration with the headmen, the councillors, who then invite members to come for a mass testing. They are given education at that spot, and the testing is done for them as well. And cases that are detected there are now again followed up by the small agent active case detection team. Next. This is actually very important. It's very important because the active case detection, it's a targeted and a very effective investment, as most of the positive malaria cases are now found near the positive cases. For example, if one case is detected, when it's followed up at the household level, so all the other positive cases that would be there are then detected and they're treated, and no more further spreading of malaria. And we are also able to seek out and treat low density infections, people who are actually maybe walking around with malaria without knowing because they are not sick. They're actually tested and treated there, and no further spread of malaria is going to be experienced there. And there is also an increase in acceptance and willingness for people to get tested because it's happening in their own community with the involvement of their own leaders that they trust. So it gives that willingness to the community members to get tested. And with the data as well, it shows that nearly half of the RDTs that have been conducted in the 2018 reports shows that these results came from the community-based testing efforts. So it's an initiative that is supporting and assisting the government to reach the elimination vision. Yeah, we have also realized that children can be very good malaria advocates. Within one of our mass testing events, we have met a special girl, Maria, who got tested and she was found positive. And just through this initiative, she was able to invite all her household members and they were all tested there, and those ones who were positive managed to get treated. So it was actually a very good approach to say, because if it wasn't for her, she came up to the testing event, the other cases could have not been detected. So it's actually vital that we have these active strategies of detecting cases in our communities to be able to eliminate malaria. Yeah, we have realized that it's actually very important to expand this model to one of the districts in the northern regions that has been reporting a lot of malaria cases. So we are expanding this model now to Okongo to be able to pick up all those last malaria cases and treat them right there and then, so we can prevent further spread of malaria in our areas. Thank you.
Thank you so much, Ndakundana. That is a very, very powerful message, taking it down to the people and showing the active engagement of members of the community, including children. Really remarkable. The director of the malaria program at the Bill and Melinda Gates Foundation, Philip Welkoff, is going to talk to us about, what it is that we have learned from experiences in the past, such as polio eradication, that we could use in the fight against malaria, and that could help us actually turn the tables, against malaria. Philip, you have the floor.
Thank you so much, Joy, and thanks also to Chris and Rebecca for the opportunity to be with you all today. And so good morning, good afternoon, good evening. And it's wonderful to be able to hear from the other panelists. I would like to commend the organizers for just the thoughtful panel and the different perspectives that have come together. It's been great to hear from national programs, from community health workers, from implementers, from funders. And I think we recognize how it takes all these different aspects of the malaria community to achieve the impact that we want to achieve together. And we all have the same goal, which is a world free of malaria. I think it's particularly useful to get the perspectives from what's happening in countries on the ground within communities. And I think as we look forward, a lot of times technical discussions on a given disease, whether it's malaria, whether it's polio, whether it's COVID, can often neglect the all of society aspect that's required to actually achieve success. We're all in this together, and it takes all the different parts of the community, of the response of the global ecosystem to actually achieve success. And I think when we have an all of society approach, we've seen some of the best successes, whether that's malaria or COVID. And when we lack it, that's where we see the gaps and we see the failures. I think it's clear that innovation of new tools, new approaches, new systems is important. But innovation and new tools and approaches in and of themselves are not enough without the community engagement, without being responsive to the needs of communities, without being responsive to what are the given constraints, what are the realities and the desires of communities and community leaders. So that's what I'm really excited to talk about today, is what can be done and what can be learned from previous work in polio and malaria in terms of both campaign digitization, but more importantly, making that information available to communities and community leaders. So I'm not going to focus on so much on the technical aspects of this approach, but on the power of the information when it's in the hands of communities and community leaders. So as an example, one of our most important metrics is going to be the countrywide level coverage of bed nets or other commodities. And that's a really important metric, and we keep trying to get that higher and higher. But we also recognize that the impact in a community, in a village, is not determined by the countrywide coverage of bed nets. It's going to be determined by the coverage of bed nets and other commodities in that village. And we want to make sure that what is the coverage in that village, what is the coverage in a local community, is known and is made known to the community members, community leaders, so that they can advocate for the coverage that they need. We want to make sure that our distribution systems actually get the nets and medicines and other commodities to the communities where it's needed most. We recognize that while bed nets are very important, it is where we have gaps in this coverage, where we have gaps in coverage, particularly in areas that are rural, that are remote, and at very high transmission of malaria, where we see the biggest need and where we have the most important need to increase coverage. So polio had a very similar set of challenges in terms of pushing for the last stages of polio elimination within Nigeria and other countries that were towards the end. One of the things that was observed, and this will be of no surprise to many people on the call, was that coverage was lowest near administrative boundaries, whether these administrative boundaries were national, state, provincial, or even district. And I think that's one reason why I'm so delighted to see the work of Isdell Flowers Cross-Border Malaria Initiative, which recognized the importance of cross-border communities and of achieving coverage and of achieving impact in those areas. There were many reasons for this, but a series of approaches was done that actually started making a big difference. It started with getting better satellite imagery of these communities and rural areas and identifying where houses were, and then putting that imagery and data in the hands of local health workers, in the hands of community leaders. In some cases, the leader of a ward would see houses that were a ways off of the main road that they didn't know actually were there. They were in their community, but they didn't realize that there was a collection of houses not too far away. That increased visibility to, especially as populations continue to grow, new settlements continue to pop up, making sure that health workers and community leaders knew where everyone in their community was, ended up being very impactful. This also allowed better maps to be made to know how health workers could actually get to distributing vaccines to each of the different households. And then this was also tied to a campaign digitization where it was understood what households had been reached and which ones had not been reached. And then very importantly, this information was in almost real time made visible and transparent to where any community could look and see, has coverage in my community been raised to the level that is needed? This made a tremendous impact, and all of a sudden we saw coverage increase including in the most vulnerable areas, including in areas that had been neglected, and in these areas that had not achieved high enough coverage before, especially the areas that were near administrative boundaries. this wasn't just about the technical approaches. This was about putting information in the hands of people who needed it, in the hands of communities, in the hands of implementers, and in the hands of decision makers at the national level, at the local level, and at the community level. And in malaria, we've started working on adapting these approaches and adapting these systems to actually make sure BedNet campaigns get to those places where it's needed the most. There's been some great work being done in a variety of countries in collaboration with Global Fund, President's Malaria Initiative. There was a particularly successful example of adapting this system and driving up higher coverage for Benin that happened last year. And we recognize that not only did the national level coverage go up, but you could see everywhere where there were gaps. You could see where were there areas that were remote, that had poor access to care, that were rural, that had high burdens of transmission, and follow-up work could be done to increase BedNet coverage in those areas. So this is about achieving high local coverage where it's needed most, empowering communities to request for and advocate for the coverage that they need, and making sure that it's not just communities that are near the main roads, not just near the capital cities, who get access to care and who get access to commodities and who get the earliest and most efficient distributions. It's about making sure that the nets get to places where they will achieve the highest impact, and that we do this for other commodities and campaigns as well. That's why collaborating with efforts such as the Isdell Flowers Cross-Border Initiative is so important, and collaborating with many of the other programs that are represented here at this venue and at this event. How can we make sure that all of our resources, existing tools, and hopefully new resources and tools have the most impact while also reaching the most vulnerable populations and empowering communities to advocate for what they need and to have the visibility when that coverage is not achieved in their community. So we fully support the roundtable today. It's wonderful to hear these different perspectives and to see faith leaders, community leaders, global funders, implementers, national program leaders, all coming together to learn from each other, to listen to each other. I've been learning a lot already, and I look forward to the rest of the roundtable. We can eradicate malaria, but it takes all of us working together. We can do it within a generation, saving many lives along the way, if we all give our best joint support, our joint efforts, and are listening and learning to each other. So thank you very much. I look forward to the rest of this.
Thank you, Philip. Within a generation, it can be done. I believe we are all in agreement. The big challenge is, how are we going to do this? Peter, you also talked about the fact that, you know, we have invested so much in the fight against COVID, yet a small percentage of that could easily eliminate malaria. So what is it that we can do right now in order to ensure that malaria does get this attention and that we do achieve this elimination during this generation?
Thanks, Joy. And first of all, I really enjoyed listening to the range of perspectives and insights from the other panelists. I thought it was a really good set of interventions. I would offer a couple of thoughts. First is that actually the fight against malaria and the fight against COVID and how we make ourselves better prepared against future infectious disease outbreaks is much closer than people sometimes. I think we sometimes get trapped in our vertical disease silos or our focus on health security. But the reality is that the best radar screen for new infectious disease outbreaks or response mechanism is the malaria community health worker network that we see in so many countries, is the coordination mechanisms, the response mechanisms that we have in national malaria programs, is the community leadership that understands what is going on in communities and can detect and respond to new threats, and can mobilize people against threats like COVID-19 and deal with issues like how do you get people to adhere to rules around social distancing or to isolation, and how do you deal with vaccine hesitancy. So I think one thing we can do is, in a sense, show that what we are doing in malaria is a strength that can be utilized for COVID-19 and for future pandemic preparedness. Secondly, I think we need to, in a sense, remove the normalization of malaria. One thing that I find somewhat depressing sometimes, in the old days when I was able to travel, was meeting ministers and senior leaders in governments who had kind of accepted a certain degree of, a certain level of how many children were dying of malaria, because it was kind of better than last year, but actually objectively was still far too high. And I worry that in communities that have kind of got used to malaria and lived with malaria so long, there may be not enough outrage to the fact that we're allowing young women, children to die of a disease that we know how to get rid of. And you've seen this very quickly in the COVID situation, where when COVID first arrived in countries, people were deeply shocked if the first 1, 2, 3, 4, 10 people died. And now, if you get down to having less than hundreds of people dying in your country per day, you start thinking, well, that's quite a good thing. And people scale, and I'm afraid to say we need to challenge these scales, and we need to definitely challenge it for malaria. Because basically the aim with malaria should be to get rid of it and not have anybody dying of it. So in essence, my answer is we need to ride the wave of the COVID response. It's the biggest thing to happen in global health. It's making political leaders think about global health in a way they have never done before. We need to position malaria as part of the solution and as part of the problem they're trying to solve, so that it's not just something on the side. And we need to raise the level of kind of outrage and with the fact that we're still letting far, far, far too many people die of this preventable and curable disease.
Thank you, Peter. Riding the wave, shouting louder, not accepting this as normal. So Raj, you talked about community health workers. And, as I listened to Peter, this looks like the biggest weapon that can be used in order to achieve all of this, to beat the drum, to ride the wave, to make it unacceptable, to actually get, the treatment and the rapid diagnosis tests in the community at the right time, as and when they are needed. Do you think it is possible to permanently institutionalize this kind of health workers?
I do think it's possible, because it's been done in some of the in countries as varied as Brazil, which is middle income, to high income countries, as well as in the poorest countries. The country I was born and raised in, Liberia, was the third poorest country following a devastating Ebola epidemic several years ago, when the president made a declaration that she would, at the time, put a community health worker, paid, trained, supported community health worker, within reach of every last community in the country. And I think that's when she did that, she did it not because this is worth thinking about. As I said in my remarks, this has always been the right thing to do, but it's also the economically and public health wise a smart thing to do. And it turns out, as Peter's pointing out, it's a safer thing to do. So let me just briefly explain why, and then what Liberia did, because I think it's such a powerful example. Liberia found that they were suffering for a lack of jobs in the country. The fastest, often healthcare is seen as a cost to finance ministers, not an investment. In fact, all the science shows it is an investment, but it's hard for a finance minister to sometimes see that when they're looking at building roads or bridges. So what is one of the fastest ways to create jobs in the health sector? It's by hiring and training a community health worker to do malaria and other primary healthcare services, and also to look for the next pandemic. So that's one, is they needed to create jobs for these workers. The second, and protect from the next epidemic. The second reason they decided to pay these workers instead of keeping them, they kept a volunteer cadre as well, but they upgraded the opportunity for professionalizing these workers. The second reason is when we look at public health. Numerous studies, the WHO already studied this in 2018, published a new set of guidelines called Optimizing Community Health Worker Programs, Policies, and Systems. This was released at the Astana Conference in Primary Healthcare in 2018. That set of guidelines was then endorsed by the UN Declaration, the UN High Level Meeting on Universal Health Coverage in September 2019. That simply means 190 governments at the head of state level and the health minister level said, this is what we ought to endorse. That set of guidelines said that the science shows that we should strongly recommend financial remuneration as well as the contracting of these workers, but also the supply chains, the training systems, the way we select these workers, all those should be optimized. And the reason they said that is because it actually results in better health outcomes. But the third and most urgent issue, as Peter pointed out, is that we now have a new pandemic of COVID-19. The countries that have succeeded in defeating or suppressing the virus and will succeed in making sure vaccines get out faster are the ones who engage and truly invest in these community health workers. The China CDC director and the Africa CDC director were both on a call on Global Health Security Summit earlier this year or last year in Germany, and they were all asked what's one single intervention that mattered most in the countries you've seen be effective at this. And they said active case finding. And we know that countries that have employed and hired thousands of these community health workers, often they were malaria workers or HIV workers or TB workers that were that added going door to door with protection to find the sick. They're doing that in India for COVID. Those are the ones that have had greater success in finding COVID-19 earlier. All outbreaks start and stop in communities. So it's just that we have to catch up as healthcare leaders to invest in them more appropriately. And we'll see the return. It will not make us just safer against COVID and malaria, but as Peter said, these workers, who are the only workers in the world that go door to door in rural areas, including urban ones, looking for fevers. It's community health workers that do malaria work, because that's the first thing you have to triage before you decide to do a test. Why does that matter? Because 60 to 75% of new emerging infectious diseases are coming from the crossover from animals into humans. And the greatest interaction between animal and human are in the blind spots of the healthcare system. They're in rural areas where sometimes Ebola gets misdiagnosed as malaria, as was the case in Guinea just a few weeks ago, or they get misdiagnosed as COVID-19. So we can help that front line, as Peter says, to be better supported. We'll do better by them because it creates jobs. We'll do better by the economies. We'll do better by public health, but we'll all be safer for it.
Thank you so much, Raj. Very comprehensive response. Dr. Joseph, very briefly, what do you think is the most effective motivation for people to accept IRS? Because you come from communities where you say you have over 85% acceptance, but there are countries where it is extremely difficult to get people to agree for their houses to be sprayed. So what is the most effective motivation that you have found in achieving this?
Yeah, thank you. Thank you, Madam Chair. IRS is an intervention that requires us or the program, the implementers, to go into people's homes. And as such, obviously, it can be perceived as the invasion of privacy and so on. We have learned with experience that you cannot have it implemented as a top-down intervention where you send in brigades into communities that are mapped from a satellite, and then you get in there, you tell people to open their homes. Definitely there will be a lot of resistance. So it's a rather bottom-up approach. You engage the communities, community leadership and all structures, having a discussion with them around the problem of malaria. Where is it happening? What causes it? How can it be averted? Once that buy-in, you also put on the table the various strategies or tools that can be used. And with that on the table, we have seen that the communities actually can tell you that this is the best intervention for this kind of setting. If we can have this other intervention here and there, and the uptake is very good, more so when you involve them in terms of who does the work, who are the people who do the operations, who will monitor and supervise to say that this was a good job done. Over.
Excellent, excellent. Very sound advice. We don't have much time left, so I am going to ask two very short and quick questions. And I'm going to go to you first, Philip, because there's a question that has been asked about the innovations that are currently available. What are the new tools in the horizon in the fight against malaria? If we were to ask you what innovation in the next 10 years will actually change the narrative at community level, what innovation would you say, very briefly?
So I think one of the most important ones is going to be going to be improved ways of reducing transmission, whether this is new forms of vector control or potentially a vaccine or monoclonal antibodies. I think we and others are investing quite a bit in developing these tools. I think one of the key things, though, is achieving coverage. Any new tool to prevent transmission, can we achieve the coverage with it in the areas that need it the most? And I think we have opportunities right now this year to say, how can we increase coverage with the current tools that we have in those communities that need it the most? And that lays the groundwork for getting the most impact out of future innovations. I think, and I think one of the things the two things that I want to mention that will probably also have the biggest impact on malaria is economic growth and development. When we see economic uplift, when we see houses being improved, when we see communities being more prosperous, that makes a tremendous difference on malaria, and also improved access to healthcare. Timely access to diagnosis and treatment makes such a tremendous difference. So I think we see several trends all moving together that will transform what's possible. I think in the new tools for preventing transmission of malaria, whether that's on the vector control side or potentially new innovations in vaccines could make a great difference. Over.
Thank you so much. I apologize that we will not be able to, go through to the other panelists, but this has been an extremely engaging panel discussion, and the underlying message is very clear. It's about communities, 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 and it's about getting the solutions to those communities efficiently, effectively, in the fastest ways possible. Even when you talk about new innovations, they have to be at the community level, and they must be brought there universally, in a quality, at a standard that will actually engage effectively and produce results. So we thank all of you for this community engagement, and we thank this community of advocates and leaders and activists, and most of all would like to thank the foundation the Isdell Flowers Cross-Border Initiative under the Foundation for organizing this panel and for leading us in this charge. We have not talked about cross-border collaboration, but the community engagement that we are talking about, the democratization of interventions, making sure that we own the data, we are adequately informed, and we participate comprehensively. That is what the cross-border collaboration will also deliver to us. And we want to thank the Foundation for this. I thank you all, and play safe, and let us live the new normal and eradicate malaria.
Thank you, Joy. Thank you, all the panelists. This has been marvelous. Our next session will begin in 3 minutes on this channel. So just stay put, but if you need to get up, you may get up. We'll begin again in 3 minutes. It will focus specifically on community engagement, though we have already been addressing that quite well. If you do need to leave and find the session back later, you can always go to jcflowersfoundation.org/roundtable to figure out how to get back into things. See you in 3 minutes. Thank you.
Hello, everyone, and welcome to our next session, Community Engagement for Malaria Elimination. We have a panel of several amazing speakers with us today who will share their perspective on engaging communities in the fight against malaria, followed by questions from the audience as time allows. I'll quickly touch on some housekeeping items before we get started. At the bottom of your Zoom window, you should see each of the icons pictured here on the slide. If you don't immediately see these icons, click the 3 dots labeled More. You may need to click your screen or move your mouse to make these icons appear. Click on the chat icon if you would like to send messages to the other participants or to the meeting hosts. Click the Q&A icon to type questions for the panelists during their presentation. The question and answer session will happen after all the panelists have presented. Our moderator will select questions that were typed into the Q&A and read them out loud to ask the panelists. If you would like to listen to the session in Portuguese, click the globe icon and choose the Portuguese language channel. And now it is my pleasure to introduce the moderator for this session, which is our very own Rebecca Vandermeulen, Executive Director of the J.C. Flowers Foundation. Rebecca, I'll pass the mic over to you now.
Thank you, Allie. The J.C. Flowers Foundation believes that malaria control and elimination demand the involvement of all of us. Most fundamentally, community engagement is the heart of malaria control and elimination. Sometimes we say that communities are hard to reach, but they're hard for who to reach? My neighbor is not hard for me to reach. Communities are not hard to reach by the people who live in them. So we believe that people living in areas with communities, with malaria, are experts in their local realities. And ultimately, they determine the success of malaria elimination efforts. Though someone living in a rural community is probably not involved in drug development, she may know exactly what keeps the village aunties from finishing their courses of antimalarial tablets. Ultimately, community engagement goes beyond outsiders informing, consulting, or involving people in a community. Fundamentally, there must be a sense of agency by those living at the local village level. They need to believe that they can play a role in malaria elimination and that they have the tools to fulfill this goal. Malaria elimination may very well require an entire paradigm shift in which people who are affected by malaria are not only included in interventions, but actually drive them. And as a foundation, this is what we are working towards. We have a nice panel here today, but I will start with one person, Halima Abdullah, who unfortunately can only be with us briefly. Halima has over 30 years of experience in public health research on malaria and other infectious diseases. She's an independent consultant, member of one of the malaria focal points on the technical review panel for the Global Fund. And she's formerly the director of infectious diseases division at FHI 360. Halima, please share with us your perspectives on community engagement and its role in malaria elimination. Thank you.
Thank you, Rebecca. I hope you can all hear me. Thank you. So, Chair, colleagues, ladies and gentlemen, I thank Isdell Flowers Foundation for the opportunity to speak at this important roundtable. I apologize in advance for not being able to stay during the whole period due to other competing assignments. I just take us back to what we have been able to listen to this morning from our very distinguished speakers. We have all heard at once each of the speakers talking about the progress made in the fight against malaria. And also we have detected the frustration in each of the speakers who have spoken before us, that the progress for the fight against malaria is flatlining for various reasons, and not least the untapped full potential of community health systems through community engagement for malaria control and malaria elimination. Now, my short remarks are really just a challenge to all of us, this committed group, to address three questions. Firstly, how are ministries of health in our countries and in all endemic countries interpreting community engagement for malaria? And more importantly, how is it implemented? Is it a deliberate exercise or an aspirational exercise? Are our programs addressing factors that influence participation, especially issues related to the power dynamics? Is it top-down or bottom-up in the strategies that we use for malaria control and malaria elimination? Also, are we seriously exploiting learnings, if any, from our engagement of communities during the malaria control phase? And also, what are we doing in terms of learning from our poster countries that are already doing very well or doing relatively well in community engagement that can assist high burden countries if they emulate the strategies? Secondly, what strategies or mechanisms work for community engagement? Is it consultation? Is it just giving them information or giving communities information? Also, are our countries really committed to community engagement beyond signing of initiatives and treaties, etc.? And lastly, for this question, does shifting tasks to minimally trained, under-remunerated cadre of frontline workers portend well for malaria elimination? Thirdly, does the malaria global community, including donors, really want to shift the power base in malaria control? Who should be driving the malaria control, malaria elimination agenda? And with that, do we have enough resources, global and domestic, dedicated to achieving this change of what was envisioned at Alma-Ata over 40 years ago? And that is the whole movement of primary health care. From my questions, I'm sure you all realize that I am also frustrated by the slow pace of getting communities fully involved in malaria control, malaria elimination, especially in resource-poor settings. But of course, we have the Isdell Flowers Foundation work in Southern Africa, which is testimony to the huge potential of this approach. However, This work needs to be replicated in Africa-wide, because the piecemeal way we are going about it is not going to solve our problem. If the primary healthcare period of more than 40 years is anything to go by, community engagement cannot continue to be an additive to be dispensed with. It has to be prioritized through rethinking of our strategies. It is even more critical in this time of COVID-19 pandemic, as we have heard, when health systems are overwhelmed, budgets are overstretched, and communities are even more vulnerable with reduced access to food, healthcare, and other essential services. It cannot continue to be business as usual. And I hope that this panel and this meeting is going to come up with ways that we can really push and enhance community engagement, community involvement, community participation, whatever we envision that to be. Thank you very much.
Thank you very much for taking time to be with us. I'd now like to introduce Henry Kalilombe. Henry is a committed community health advocate with more than 20 years of experience addressing malaria, as well as HIV and TB at the community level in Livingston District in Zambia. He's currently the vice chair of the Livingston District Malaria Task Force, among many other duties. Henry, over to you.
Thank you very much for actually allowing me to take part in this actually roundtable discussion. I'll start with actually thanking the chair. I also want to thank Isdell Foundation Malaria Cross-Border Initiative for actually availing me this opportunity to participate. I'm so grateful. Let me just quickly introduce myself. My full name, as already mentioned, I'm Kalilombe Henry, the vice chairperson for Malaria Task Force Livingston. I'm also in charge of a number of committees in the district. I'm also the district TB and HIV committee chairperson. I'm also about health committee chairperson at the Way Health Center. So basically, I'm quite involved in a number of activities. But I think today we will focus mainly on the thematic, which I'm also the vice chairperson. I've been the past chairperson for the past, I think, 10 years when I was a chairperson until last year when I was actually elected to be the vice chairperson. MATIF is actually a community body which is locally formulated within the district. It is a composition of all a number of stakeholders within Livingston. For example, NGOs that are operating in the Livingston district. We also have the business institutions like the banks. We have also the business, other business institutions like those in the retail businesses. So this body actually come together and form what we call the District Malaria Task Force. But however, there are a number of responsibilities that this committee is actually tasked. One of the responsibilities that this committee is tasked is to mobilize actually the resources that are required in the fight of malaria in the district. As you are aware, malaria is not only meant for the Ministry of Health, but a cross-cutting actually issue that needs all efforts to be actually pushed together to find solution. However, there are a number of activities that the Malaria Task Force should actually assist the district putting in place. For example, there is a campaign for IRS. The District Malaria Task Force will be responsible to put up all the logistics that are required in the district for them to actually carry out the IRS program. If it's the distribution of ITNs, the task force is also responsible to make sure that all the small logistics in terms of transport, where they're supposed to go, in terms of who's supposed to be responsible, the task force will actually pick it up from there and help in actually fighting the disease. But however, if you look at the district level, this committee mainly focuses at the district level. But we have also gone further to make sure that we also form what we call community malaria task force in all the health centers. This normally helps to scale the effects, to scale down the services to the community level. And I think during my term of office, we managed to actually form a number of malaria task force, community malaria task force. And when we look at the community malaria task force, This is a typical community-based malaria task force composed of local partners within that catchment area. We have schools in that catchment area. We actually involve the schools, the agriculture department, the traditional leaders, the churches. These people I've mentioned are very key, and those influential leaders that are found in the community are also actually involved in this formation of the community neighborhood health committee. As I mentioned earlier on, to say I'm also one of the community health workers for the past 20 years. I think during my term of office, I think community health workers play a very significant role in actually reducing malaria cases. There are a number of benefits or advantages of involving the community. As you are aware, the health institutions only focus at the facility level, but the involvement of community health workers who actually take the service right up at the doorstep, meaning that when the service is actually delivered at the doorstep, it will be effective, it will be on time, and actually it will save a number of time. Above all, when you involve the community of workers, these people that you are involving are still in a certain community area. They understand the language. You know, here in Africa, when we talk about issues of language, we have about 72 tribes here in Zambia. So you need people who are still in the same catchment area, who speak the same language, who understand even the cultures. You know, our cultures here in Africa are very different from one place to another. So when you use the same local community, they understand very well the language, the geography, even the geography that they are operating from. They know that this is the type of the terrain which we are supposed to be actually going through. Above all, the community health workers are so key in actually reducing malaria cases. Why am I saying that so key?
Henry, thank you so much, Henry. We're having some difficulties with the line. We may be able to come back to you for now, but thank you for what you have already shared. What I think I'm really intrigued by is that Halima began by talking about how we need to not just do task shifting to community members, but actually also shifting of responsibility, and with responsibility, also authority. What I see Henry showing us now is an example of shifting of responsibility to that local level. We often think about private sector involvement at a global level, but what I'm hearing now is private sector involvement at the very local level, including at the local shop owners. This is an example, Henry, of community engagement. Thank you. We'll see if we can come back to you later, but thank you very much. I'd now like to introduce Erica Larson. Erica is the Director of Advocacy, Financing, and Sustainability at the Malaria Elimination Initiative of the University of California, San Francisco. Welcome, Erica.
Thank you, Rebecca. It's a pleasure to be with you all today. And Rebecca, that comment on shifting authority is a perfect segue to what I'll be presenting on. I'm Erica Larson, as Rebecca mentioned. I'm the Director of Advocacy, Financing, and Sustainability at the University of California, San Francisco Malaria Elimination Initiative. And I was invited to this panel to present the findings from a background paper we did on community engagement. And I'm presenting on behalf of the MEI team that led the work. Next slide. So I thought I would first set the scene for community engagement with this figure. And this figure shows different levels of engagement between public health practitioners and the communities they serve. So moving left to right, the continuum shows what an increasingly equitable relationship looks like. Traditional approaches to community engagement typically exist on the left side of this continuum, where public health practitioners only inform or consult the community, primarily for the uptake of interventions. And community engagement is often implemented in a top-down manner, where policymakers or public health officials are establishing objectives or developing action plans. The problem with this approach is that the authorities tend to perceive the needs of the communities differently than the communities themselves. When implemented as a participatory process, so on the right side of this figure, community engagement directly involves communities in decision-making, managing activities, and measuring results. And this approach has potential for several positive effects, including improving program design and implementation, resulting in efficiencies and sustainable results, and also reducing operational risks by ensuring programs are relevant and responsive to local context. And these benefits are of particular interest when you consider some of the operational challenges to malaria elimination, including targeting and tailoring of interventions to specific populations or communities. In 2015, the RBM partnership called on malaria programs to involve communities in the design of malaria programs and implementation. Next slide. Given this broad support, community engagement should be the center feature of malaria programming. However, it is not consistently defined, operationalized, or evaluated, and there's a lot of differences in the ways that it's incorporated into practice. And this has led to a number of different activities, strategies, and programs, all commonly referred to as, quote, community engagement, even though the goals and outcomes vary. And this, in the context of malaria, other important gaps have been identified, primarily the lack of adequate human resource capacity related to community engagement, insufficient funding and interest in issues related to broader health system, and poor definition of operational criteria for effective community engagement. Next slide. So we set out to develop a background paper to address at least some of these gaps by looking at effective models of community engagement in malaria, but also in other health areas, including guinea worm, NTDs, nutrition, and HIV. We reviewed 10 programs from 7 different health areas and conducted focus group discussions and key informant interviews. And I won't spend too much time on the methodology. If you're interested, I'll put a link in the chat to our paper and you can read more. Next slide. So our results indicate that the importance of a common understanding and definition of community engagement. And we proposed this definition, where community engagement is a participatory process that actively involves community stakeholders in the design, governance, delivery, monitoring, and evaluation of malaria services. Next slide. We found that community engagement is well utilized in many sectors, including health programs, and guidance about how to do excellent community engagement exists in many manuals and in almost all settings, and communities are organized and open to engagement. But it appears that the main barriers to progress are within the malaria community itself. Primarily, national malaria programs and their development partners conflate or confuse community engagement with strategies like IEC, SBCC, and community health worker programs and other community-based interventions. However, community engagement is more than this. It's a participatory process that goes beyond what activities and strategies are implemented and considers how those activities are designed, implemented, and monitored and evaluated, as well as who is involved. Next slide. So our results indicate that there are a set of mutually reinforcing common principles that support effective community engagement. I won't go into each of these, but I did want to highlight 2. First, community engagement's often implemented as a one-off activity. But proactive and continuous community engagement that's integrated, and this is important, integrated with other health and development priorities makes a bigger impact. And this prolonged interaction between health professionals and the community enhances trust. Second, effective community engagement treats the community as partners and works with stakeholders to identify problems and implement solutions. Communities are involved in decision-making processes, including program planning, implementation, monitoring, and evaluation. Next slide. And I really wanted to focus on this particular point. We did outline a few operational strategies for community engagement, including leveraging community health worker programs, as has been discussed in the plenary, and other strategies. But I wanted to focus on one particular operational strategy, and that is to decentralize program management and service delivery. Effective community engagement involves moving decision-making to the users of health services, and this requires strengthening links between communities and local health units. So feedback loops that go from communities through local health units to national level policymaking and back to communities can support this process. Generally, we found that there are strong linkages between communities affected by malaria and their local leaders, shown here in green, as well as good coordination between national malaria programs and district level health units, shown here in blue. However, there's often a large operational gap between the community structures and the district level health service delivery. And this gap ultimately undermines the impact of community health worker programs and village health committees. Next slide. So for participatory community engagement to work, the health system needs to focus on building formal linkages between decision-making bodies and the community. Next slide. In our paper, we propose this operational model. I'm sure there are many, and look forward to hearing from you all in the Q&A period. But this model reimagines the roles and responsibilities and relationships between national malaria programs in the green box, the district level health units in the blue box, and community platforms in the red box. Here, the community and district work together to identify and implement operational challenges and solutions. And the district then feeds community level feedback to the national program. And the national policies and strategies change in response to that feedback. We acknowledge this proposed model relies heavily on perhaps weaker components of the health system, including district health units, which often lack the capacity to execute the technical and administrative tasks. But in order to eliminate malaria, it's critical that we work on these challenging issues. Next slide. So I wanted to end with two slides on the recommendations that we set forth for national malaria programs and their partners and also donors. So for the national malaria programs and their partners, we encourage district health units to map existing community platforms. And if none exist, work with community leaders to build new platforms. Recruit trusted leaders in the community space. And as I mentioned, importantly, link community platforms with the health system. And you can do this by developing policies, standard operating procedures, and accountability frameworks. Co-create malaria action plans with communities. So moving away from communities just being the receiver or recipient of information and really co-create action plans with them. And then, of course, coordinate routine community engagement with those district or administrative units closer to the community. Next slide. Importantly, we also propose recommendations for donors and acknowledgement that they incentivize or structure how malaria programs often operate. And here we ask donors to promote a more rigorous definition of community engagement and incorporate the UNICEF minimum quality standards and indicators for community engagement. And these are not specific to malaria, but set forth the strong principles that we found to be effective. We also ask donors to recognize the costs of strengthening community engagement and that it may take a long time for community engagement to bear fruit. And so we ask donors to allow for greater flexibility in the use of funds. And then finally, as we know, often if community engagement is not in the proposals, budgets or M&E frameworks, it will not likely be done. So we ask for that requirement. Next slide.
Thank you, Erica.
Thank you.
Marvelous. Great to hear an academic perspective on the things that many of us feel and don't necessarily have the language to put on it. Thank you for that. I'd like to welcome now Olivia Ngo. Olivia is the founder and executive director of Impact Santé Afrique and the Civil Society for Malaria Elimination Network. Welcome, Olivia.
Thank you very much. Thank you, Rebecca. I hope you can hear me well.
Yes.
Okay. Thank you very much. Can you hear me well?
Yes.
Okay,
Try to keep the camera still. We can hear you perfectly.
Yes. Thank you. So thank you for the opportunity to speak today. And I'll be very brief, but I will talk about community engagement in malaria. So in the malaria fight, at this moment, so we think that we need a mechanism to deliver programmatic assurance of the impact of malaria funding at the community level. It will ensure not only accountability to the people living and the most at risk of malaria, but also it will ensure that we have a very strong malaria program. So continuous monitoring of the quality and accessibility of malaria service, but this has to be led by communities who are themselves the service user. It's necessary to highlight the barrier to those service delivery and also use advocacy to correct any problem through monitoring. So community-led monitoring really works when it includes sufficient number of sites of service delivery, and also when it's implemented by independent community networks who are themselves users of the services that are being monitored. And they know exactly the problem and how to solve the issue. So we believe that partners should invest in building community-led monitoring, especially in countries facing poor program performance for malaria. Such investment will increase the impact of malaria-funded grant, but also accountability of service providers to the clients. So there's several key prerequisites to make community-led monitoring and effective interventions for malaria, for improving both the quality of malaria services, but also accountability. So the first one is community-led monitoring must be owned and led by communities. I think many speakers say that over and over, because people directly affected by a weak or failing malaria response have the greatest stake in designing and monitoring the malaria services and policies that will improve their current experience and then the outcome. So communities are often the first one to detect and diagnose problems, and monitoring gives communities that capacity to share what they know with decision makers and also fight to ensure that their needs are met. Secondly, organized communities are required for effective communities, because an individual could be hired one by one from communities to collect data, but it doesn't allow for a later step or translating those data into action. So it's not just about collecting information, but it's about what action is being taken once we have the information. So the most effective community-led monitoring efforts that are based out of organizations or coalitions of organizations who are in organized groups or branch in communities will bring multiple voices at the local level, and will then therefore increase power and like a structure or mechanism capable of managing those efforts. So many voices are better, and we encourage partners and our local governments to increase their support in community-led monitoring coalitions of networks of organizations. And this will help to bring the community system, and that will then increase the quality of malaria services. So third and lastly, a focus on generating political will and accountability is key to make sure we can improve the programs on the long term. So like I say, information alone is critical. It's not alone is not sufficient, but we need decision makers to be engaged for the long term to not only solve the current issue of stock out, but to ensure that the whole system is reinforced so we don't have 3 months later the same issues of stock out. So information, so problem exists for a reason. So we need to understand why those problems exist, the root of the problems, and work with our decision makers and political leaders to solve those problems. So a real political analysis is really needed to address those issues. So those are some key points, and this is based also on the experience of our of civil society colleagues working on HIV and AIDS, because in malaria, we still need a lot of effort. We still need a lot of work to be able to implement these recommendations. But we hope that in the malaria community, we are going to start to implement community-led monitoring, not community monitoring, but community-led monitoring. There's a huge difference between the two. It has to be led by community, and it has to also involve decision makers to ensure sustainability and to ensure that we solve the root and the causes of the problem, to increase access to malaria services for everyone. Like we always say, leaving no one behind. So thank you very much, the GC Flower Foundation, for the opportunities. And we really look forward to continue to work with all of you to make those change and improve malaria services. Thank you.
Thank you, Olivia. And please check out, all of you, cs4me.org for good resources. We're going to close with a short video from Angola. It's a poor recording, but it's a remote area and we think it will still be worth it. After this session, we will have an additional Q&A. We'll come back and just have a conversation about this. Thank you.
I am here to present to you our next speaker, Justina. I am Nelo, and I support community malaria work in Cubango, Angola. It is a very remote part of the country, and most people lack easy access to healthcare. My colleague Emilia has been leading the work in the neighboring province of Cunene for much longer, but with the support of the E8, the Global Fund, the Gates Foundation, we began to work in Cubango 3 years ago. Our role in this partnership was focused on demand generation. As you will hear, Justina has done an excellent job on this demand generation. We are currently working with the Ministry of Health to train some volunteers to test and treat as ADECOs, which are Angola's community health workers. The ADECO's role has a stipend. We are excited to see Justina become an ADECO as well as a volunteer for demand generation.
Well, they should trust volunteers simply because having volunteers in the community, it helps a lot. Having volunteers in the community, it helps the community malaria intervention, like the coverage. They help the community, like more especially this time of COVID pandemic. People can't cross, like seek for help other than just depending on volunteers. Volunteers are really helping. Volunteers are most important simply because when someone is given medicines at the clinic, volunteers used to do follow-up to that person, whether the person is taking the medicine or correctly, or whether the person was, sometimes some of the people, they can just take the medicine and keep it at home without taking it. Coming from Rwanda and want to meet me at my village, the person needs to come from Rwanda up to Menonge. And from Menonge up to our village is 745 kilometers. The person has to proceed at our village. And the person need to use a car like Land Cruiser 4x4 because the street or the road is not good for any type of a car.
O trabalho do voluntário na comunidade é muito importante, porque o voluntário é que exige as pessoas para conhecer a malária e para tomar o tratamento da malária. Todos os cuidados com a malária, o voluntário bem treinado, ele consegue ajudar as pessoas. Porque há pacientes que vão buscar medicamento na unidade, mas ele não consegue acabar a dose. Então, com a presença do voluntário na comunidade, ele exige com que acabem de tomar os medicamentos. Muitos doentes, por estar distante com as unidades sanitárias, ou seja, há comunidades que estão a mais de 15 quilômetros para ele encontrar um hospital, preferem ir nos curandeiros. Então, o voluntário treinado na comunidade, ele consegue sentar essa família para que procurem mesmo os serviços da saúde, porque há sinais e sintomas da malária que pode alguém que não sabe entender que pode ser uma coisa de tradição, afinal não é malária. Então, o voluntário bem treinado na comunidade consegue ajudar que essas famílias procurem os serviços da saúde.
We want to get down to zero. We just want to eliminate malaria for good.
Thank you. This is the reality in hundreds and thousands of villages around Africa, that there's a team of volunteers who are supporting the health systems.